I want to welcome everybody to the Molecular Pathology and Genomics and Computational Pathology Research Symposium, hosted by the Department of Lab Medicine and Pathology at the University of Minnesota. I want to thank everybody for joining the meeting today. So before we move forward with the meeting agenda today, I just wanted to remind everyone that the session today is people can get both CME credits and self-assessment SAM credits for attending the symposium. If people want the CME credits, I encourage everybody to go in and complete this evaluation of the symposium. But once you complete the evaluation of the symposium, you can also claim the CME credits there. And then if people want SAM credits, they have to go to this link, the Z link, and complete the questions before August 10th of 2020. Right. The disclosures for this meeting. Most of the speakers and course directors don't have any disclosures to make, except Dr. Colin Pritchard, who's been a consultant for Promega. I would like to thank all the planning committee members and specifically Caroline Hallstrom down here for taking the lead and really organizing this meeting and getting everything set up. We had to scramble to move this meeting from an in-person format to the virtual Zoom format. And Caroline has done the bulk of the work to make that happen. So big shout out and thanks to her for doing all this work. The agenda for today, after this short welcome, we'll have our first keynote speaker, Dr. Colin Pritchard. He's an associate professor in the University of Washington, and the director of the genetics and solid tumors lab out there. And he's done a lot of work developing diagnostic panels for both colorectal cancer and prostate cancer, as well as, I believe, led the development of the OncoPlex, the UW OncoPlex assay in Seattle as well. Following that, we will have Dr. Andrew Nelson from the University of Minnesota, who's going to be talking about the work he's been doing with the ovarian cancer precision medicine initiative here at the University of Minnesota. And that will be this is the first half of the symposium is the molecular pathology and genomics piece of this. And then the second half of the symposium would be the computational pathology piece of this, and Dr. Nathan Pankratz, who's the director of the computational pathology division, will introduce Dr. Lennox and Dr. McIntyre, and we'll go from there. One thing before we start the meeting today, for all the participants, if you want to ask any questions during the talk, please use the question and answer button on the Zoom screen and submit your questions. At the end of the talk, Carolyn Hallstrom will read out the questions so that the speakers will have an opportunity to answer any of the questions that you may have. For the speakers, I would just like to point out that around 5 minutes before the end of your allotted time, I will just give you a reminder that it's 5 minutes remaining. Other than that, we should be all set. Dr. Pritchard, please take it away.
All right. So it's really a pleasure to get to do this, if virtually only. Let me make sure this. Am I not sharing yet? I'm not sharing yet, am I? Okay. All right. And for the people who I can see the video, you can hear me okay?
Yeah, just the display settings, share.
Thank you. It reverted back. Okay.
Always does on Zoom.
Always does. All right. Well, it's a pleasure to be here, and thanks to the organizers for inviting me to this virtual presentation. And I'm really thrilled. I have a whole hour. I might not use the whole time, so maybe we could even be early. And my understanding is that there'll be questions kind of coming in throughout, but we'll save them for the end for chat. I'm going to talk about a theme, and that theme is sort of crossovers between somatic cancer testing in tumors and inherited germline testing for predisposition, and how those things are two areas that are really kind of inextricably related, and increasingly so because of therapy that's guided by both germline and tumor findings, but also a lot of other ways that are interesting and emerging in clinical diagnostic testing. So I do have these disclosures. I was mentioned I'm a consultant for Promega, also AstraZeneca. So there's interplay between tumor and germline in a lot of interesting ways. And I've not listed all of them here, but these are the three that I'm going to focus on. So the first area of interplay is with targeted therapy. So particularly a relatively new class of targeted therapy called PARP inhibitors, also immunotherapies. So mutations in homologous recombination DNA repair genes, which I'll talk a lot about, we'll hear about from Dr. Nelson next too, guide targeted therapies with both of these. And increasingly, the FDA approved indications for these therapies are based not only on tumor findings, but on germline findings. So, even in the course of someone who has cancer, who your primary goal is to just identify what to treat them with, you really need to be thinking about the germline. The second area of interplay is in cancer syndromes. So I'll talk about some interesting ways that we can use tumor normal testing to try to diagnose cancer syndromes and how those interact. There's also interesting ways that those tumor and germline testing can interact in terms of variant classification when you're working up a cancer syndrome. And then the third topic I'll talk about is liquid biopsy. So you would think that this would be kind of separate, but really, there's also really interesting areas of interplay between tumor and germline and liquid biopsy, because of course, we're testing the blood to begin with, and the blood is our main source of germline or inherited mutations when we look for them. But there's also interesting, I think, ways that somatic findings in blood are interplay with both the cancer you're looking for and then what's interfering with that. So I'll talk a lot about clonal hematopoiesis versus germline versus the cancer you're trying to measure. And that's really a story it's a known story, but it's still something that when I talk to my oncologist colleagues, they really haven't quite internalized how critical that is in terms of this testing modality. So those are the three topics. So the outline of the talk. So at the beginning, I'm going to talk mostly about DNA repair gene mutations in cancer treatment. I'll talk about background and then testing approaches, and then I'll talk about tumor sequencing and a germline workup, and then liquid biopsy. So there are many DNA repair pathways, at least 6, depending on if you ask an expert, maybe they'll say 8 so or more. We really focus on 2 main DNA repair pathways of these myriad pathways that cells use to repair their DNA, because they're actionable right now. And those 2 pathways are homologous recombination DNA repair and mismatch DNA repair. So what are the genes that are the poster children of these pathways? So homologous recombination DNA repair genes, the poster children are BRCA1, BRCA2. There's a germline syndrome associated with it. I prefer to call it King syndrome after Mary Claire King, who discovered the BRCA1 gene, which is exactly analogous to what we call Lynch syndrome. It's currently called hereditary breast and ovarian cancer syndrome, which is a terrible name because it's not just breast and ovarian, it's also prostate cancer and pancreatic cancer and many others. Also, that's just a really cumbersome name to say. So I think we'll see where that goes. But for right now, the germline syndrome associated with if you have an inherited mutation in BRCA1 and 2 is called hereditary breast and ovarian. The treatment implications, so PARP inhibitors. So these are the poly-ADP ribose polymerase inhibitors that are generally effective when you have biallelic, that is both copies of a homologous recombination DNA repair pathway gene knockdown. And not all genes are the same, and we'll talk a little bit about that. Platinum-based chemotherapies also tend to work fairly well on tumors that have this DNA repair pathway knocked out. The other main DNA repair pathway is mismatch repair. We've been testing for this in pathology and lab medicine for years. There are 4 main genes. I'm listing a couple here: MSH2, MLH1, also MSH6 and PMS2 are genes we test for routinely. There is a germline syndrome, that's Lynch syndrome. If you have mutations in one of these 4 genes, I'm only listing a couple examples here. You have predisposition to colon cancer, also endometrial cancer. Rolls off the tongue a lot better than hereditary breast and ovarian cancer syndrome. And there is a treatment implication. As of about 3 years ago now, we have a checkpoint blockade immunotherapy that is FDA approved for any cancer, regardless of cancer type, that has evidence of mismatch repair deficiency. And that can be either through looking for the proteins being lost through immunohistochemistry, or through the characteristic mutation signature, which we call microsatellite instability. So the interesting thing about this is the treatment, because we've been testing for mismatch repair deficiency for 20, 30 years routinely in pathology and lab medicine for Lynch screening. So the new kid on the block here is the fact that there's a treatment implication. Okay, and I think Dr. Nelson's going to cover this quite a bit in the next talk, so I won't talk too much about PARP inhibitors and ovarian and breast, but just suffice it to say that there are multiple PARP inhibitors approved now. And they've been approved for not just ovarian and breast, but most recently in 2019 for pancreas cancer. And then in 2020, about 2 months ago, mid-May of 2020, 2 PARP inhibitors were approved for metastatic prostate cancer. And there's probably more to come. So that's exciting. All of these PARP inhibitors, the FDA approval is based on germline BRCA1 or 2. Some for somatic as well. And some for homologous recombination DNA repair genes beyond BRCA1 and 2. So, for example, PALP2. And that's somewhat controversial, particularly genes like ATM that aren't really in the homologous recombination DNA repair pathway and yet are on label. I would be paying close attention to the literature and seeing what happens with that. So it's going to be interesting to see what happens with the sort of long tail of genes. But because of this, germline and somatic BRCA1 2 testing is really becoming standard of care for a wide swath of cancers, because you need to know both the germline and somatic status in order to do standard of care treatments. So where did this come from? So there's been a lot of data in breast and ovarian. I'm going to focus on some of the data in prostate cancer, which is the cancer type I know best. So this is just one example of extraordinary PARP inhibitor responses in a DNA repair-mutated cancer type prostate cancer. So this was a phase 2 trial, the TOPARP trial led by Johan de Bono's group and Joaquin Mateo. I wasn't involved in this study. But this was published about 5 years ago. And what they showed was just kind of remarkable stratification of responses according to DNA repair mutation status. So it was a small series. But in this series of men with the most advanced type of prostate cancer, metastatic prostate cancer, 16 of them had biallelic inactivation in one of these DNA repair genes listed on the left. And 14 out of 16 of them had a response to a single agent PARP inhibitor, compared to only 2 out of the 33 that didn't have one of these. So this is just remarkable stratification. We've never even seen anything like this before. So these really are predictive. The truth of the matter is it's not probably quite as predictive as this early study suggests, but it's still really good. So particularly BRCA2 in prostate cancer is really, I think, very highly predictive of PARP inhibitor responses. And we've seen that again and again. And this is true for other cancer types too, particularly BRCA1 and 2. And then I mentioned the controversy in the long tail, but I think a lot of these other homologous recombination DNA repair pathway genes are going to be predictive, just the emphasis being that all genes are not the same. So we are going to have to study each gene individually to understand what its profile is in terms of predicting response to these drugs. So germline DNA repair mutations are common in metastatic. I was led by a large team. I was lucky to be the lead author on a study across 8 institutions where we looked at metastatic prostate cancer and germline mutations. And we sort of stumbled upon this because we were focused on somatic. This was part of the Stand Up to Cancer Prostate Cancer Foundation International so-called Dream Team collaboration, where we were looking at primarily we were focusing on defining what are the somatic mutations in metastatic prostate cancer, because that hadn't really been defined in the metastatic setting before. And I was really the only one on the team that really had really deep expertise in germline, because I was doing it. We were doing germline predisposition panels clinically through our clinical lab, and so this is what I did as a clinical lab director, day in, day out, is cancer predisposition panel testing through our so-called BROCA panel. And so I said, well, geez, I think we should be looking at it. And we had the data. And when I first got the result, I just couldn't believe it. It was like 10% of these guys had, high penetrance, single gene mutations in genes we already know about: BRCA2, BRCA1, ATM, PALB2. The list is shown here. So it was really quite remarkable. And so in our series across 8 institutions, 12% of these guys with metastatic prostate cancer had a germline mutation. And these weren't patients that were selected based on family history or age or anything. This is basically, and these were different series. So it was quite remarkable. And then importantly, because we had the tumors on these guys, we could show that in the tumors where we did have an available study, that there was evidence of that biallelic second allele inactivation. That is evidence that this germline mutation really might have or did cause the cancer in a majority. So that was important too, to say, well, these aren't just true unrelated, but it really looks like these have a role in causing the cancer, or at least cancer progression. So that was exciting because it opened the door to a whole host of applications for men with metastatic prostate cancer in terms of genetic testing. So another exciting finding that I had no involvement in, but was quite exciting across all cancer types, is the FDA approval of the PDA1 inhibitor, in this case pembrolizumab, for any mismatch repair-deficient cancer. So this was historic. This was back in 2017. It was historic because it's the first time the FDA had approved a cancer-agnostic biomarker. So what I mean by that is that the biomarker tells you the drug, not the cancer type. So it's not like you have mismatch repair deficiency in colon cancer, therefore you get this. It's any cancer type. It doesn't, it could be sarcoma, it could be breast cancer. So, one could debate whether that was a good idea or not. I think it probably was, but it's really interesting, that it was done that way. And I think that's going to increasingly be the modality going forward as we have more and more targeted pathway targeted therapies that we're going to get more cancer agnostic approvals. So that really opened the door up to testing for mismatch repair deficiency in a more broad way than we had before. So as I mentioned at the beginning of the talk, we've been testing for mismatch repair deficiency using immunohistochemistry for the mismatch repair proteins. Again, that's MLH1, PMS2, MSH2, MSH6. And we measure the sort of genomic signature that's associated with lack of this pathway, and that's microsatellite instability, or MSI. And so we've been testing this for years, but really the floodgates just opened when this immunotherapy got approved, because now, instead of just testing this to look for screening for the cancer predisposition for the germline mutations in mismatch repair, now we needed to test every cancer type basically to look for if there was somatic mismatch repair deficiency for immunotherapy. And so I imagine at Minnesota and other institutions, the floodgates opened a few years ago too. So we were really interested in this for other reasons going back years, and we developed some methodology around next generation sequencing to detect MSI. And so this is some nice work led by Steve Salaponte and Jennifer Hempelman in our group. And what Steve did is he developed some software to detect microsatellite instability from next generation sequencing. So the story I'll tell on this is I think I don't have that many slides, so I think I can tell the story. So I'm again, the theme here too is that it's doing clinical work day in, day out can really result in really interesting research discoveries. So we're looking at our panel, which is UW OncoPlex, and we're looking at this day in, day out, and I'm looking at these microsatellite instability high cancers that I know are MSI high based on other methods, and I can see it in the data. I'm looking at the raw data, and I'm like, I can see the microsatellite instability. I can see that the sort of, when you have microsatellite instability, these are these short repeats that sort of expand and contract, and you see. And you can, when you look at the raw data, I can see that. I said, Steve, if I can see this in the data, we can script this, right? So yeah. So we made some software that we call MSINGS for MSI by NGS, and we've now applied that software to I think 5 or 6 different panel tests that we use. So we test MSI by a number of different tests now. So this was just one of those examples. I'm showing here, which was what we call the MSI Plus assay, which is just a targeted like 18 PCR, multiplex PCR, so very cheap and easy. But we also apply this to large panel tests. We apply it to medium panel tests. It's nice because you can apply it all over the place. And the nice thing about by doing MSI by a next generation sequencing is you can interrogate so many different microsatellite loci. In traditional capillary electrophoresis methods, you're only looking at 5. It's going to go up a little bit. But in next generation sequencing, it's really the sky's the limit. So you can get a more robust signal. And this is particularly important now, too, because it turns out that MSI is not the same across cancer types, which is very inconvenient. And yet the assays that we've used for MSI really have only been validated for colorectal cancer and maybe endometrial. And so we're applying an assay. So when we use an off-the-shelf MSI assay, like a capillary electrophoresis assay, like a historic one, it really isn't that good for outside of colorectal cancer and endometrial. And that's the bottom line. So it matters, and this is again more work led by Steve Salponte's group that I was lucky to collaborate with him on. And what he did is he applied the same software that we had developed, the MSync software, and he looked at TCGA data sets. Those are the cancer genome atlas data sets, and he looked for patterns of microsatellite instability across exome sequencing, where you can interrogate thousands of microsatellite loci. And then what's shown in this heat map is just sort of clustering cancers according to their MSI signatures. So these are cancer types that are MSI high, but in different ways, right? So it turns out that, again, I really want to emphasize this point, that MSI signatures are not the same between cancer types. That doesn't mean that, but I'm not saying that some cancers have more MSI than others. That's also true. That's not what I'm saying. What I'm saying is when you have MSI, the signature of MSI, that is the exact loci that are mutated, are not necessarily the same ones. So that means from an assay standpoint, if you're only interrogating 5 loci out of hundreds of thousands that you could have chosen from the genome, and those 5 loci were optimized for colorectal cancer, we have a problem. And we saw this with prostate cancer. So when we looked at the 5 marker capillary electrophoresis panel in gold standard mismatch repair deficient known prostate cancers, we found that was only 70% sensitive for detecting it. And then not surprisingly, when we used a large panel of loci that includes loci that we know are more frequently mutated in MSI high prostate cancer, it performed way better, about 95% sensitive. So I think that what this means is that, as we're doing mismatch repair deficiency testing by many methods, very broadly across many cancer types, I think what this means is that we're going to need to be thinking about NGS methods or expanded capillary electrophoresis panel methods. I don't think we can get away with this 5 marker MSI method for all these other cancer types. It just doesn't work well enough, and it's just too important to get the answer right. So the good news is there's a lot of new assays coming out. I think most of the diagnostics developers recognize this issue and are developing new assays. So it's not like every lab has to develop their own, NGS panel or something like that to do this. I think there's going to be a lot better assays, and there's some already hit the market. Okay, so the other thing, signature-wise, I think is worth talking about, and I think, again, Dr. Nelson will cover this in the next talk, so I won't I won't go too much into it, but the signature of homologous recombination DNA repair deficiency. So talked just a lot about MSI as the signature, the mutation signature of mismatch repair deficiency. Well, there's sort of an analogous mutation signature with homologous recombination DNA repair deficiency. It's just much harder to measure, and we haven't been doing it for 30 years like we've been doing with MSI. But it really is exactly analogous. Like HRD is the MSI of BRCA1 and 2. You know, that's the way I like to explain it. So it's not scary. It can be measured. There is a genomic hallmark or scar or whatever you want to call it. There's a mutation signature associated with it. But to measure it accurately, at least with the methods right now, it is really optimal to do paired tumor normal testing. And again, getting back to this theme of interaction between tumor and germline, HRD might be what pushes us this way, because it really is much more accurate to detect HRD when you're doing a paired test with both a germline control and a tumor sample. And so there's a number of different hallmarks of HRD signature you can look at. There's high levels of genomic loss of heterozygosity, and that has to do with the homologous recombination DNA repair pathway being out. So you get these double-strand breaks, which result in high burden of LOH. You get deletions at areas of microhomology, and that has to do with the sort of rescue DNA repair pathway, which is non-homologous in-joining that comes in and sort of a signature of too much non-homologous in-joining pathway. And you get lots of large rearrangements, which are sort of due to both of those things. And there's a few other things, like there's a single nucleotide signature, which I'm showing at the bottom. So HRD signatures are coming. There already are some assays out there. There are going to be a lot more coming, I think, because of the increased PARP inhibitor approval across cancer types. And it's great to look for mutations and for like biallelic BRCA1 or BRCA2 inactivation at the mutation level, but that's not always going to find HRD. That is the signature. It's like if we started, instead of using IHC or MSI assays to look for mismatch repair deficiency, let's say we just started by just looking for the mutations in the genes. Well, that works, but you are going to miss some, and you'd probably rather just look for the signature. That's what we already do with mismatch repair. Why don't we do that for homologous recombination DNA repair? So we're going to start doing that. And there, like I said, there's already commercial assays out there. They're coming fast and furious. HRD signatures have been shown to be associated with clinical utility. This is data from Liz Swisher's group, the Ariel trial in ovarian cancer, showing that if you have LOH high, which is the HRD signature, those patients did better on platinum or on PARP than on patients with LOH low. But importantly, mutations still did perform the best. But I think that the issue here, though, really isn't necessarily that mutation testing performs better than signature testing. I think the issue is that signature testing isn't quite there yet. So we're not doing that well with signature testing. I think when the signature tests get really good, then that'll perform as well or maybe even better than mutation testing. So we have a ways to go. It's a challenging thing. It's a challenging nut to crack. So this is just a little bit about the implementation of next generation sequencing testing at our institution, the University of Washington. Again, the theme being germline and somatic. And so we've been doing large panel NGS testing for about almost 10 years now. So we started in 2011. And we actually started on the germline side. So we started with cancer predisposition with a test called ColoSeq, which was for Lynch Syndrome predisposition. And then in collaboration with Mary Claire King's lab, we brought on the BROCA panel, which is sort of a pan-cancer predisposition. Around that same time, we brought on our tumor panel, UW OncoPlex. And then we've added, I'm not going to go through all of these, but we've just added more and more panels throughout the years. And it really isn't one size fits all. It's not like, what do you use for your cancer or what do you use for your germline? We have so many different panels, and we found that works really well because it focuses the question and it allows us to design assays that can really be optimally sensitive for the regions that we want to test. And even in 2020, when sequencing costs have come down and whatnot, it still really makes sense to do deep coverage of exactly the genes you want to look at. And you can do things like, for example, we target all the introns of the mismatch repair genes. We target all the flanking regions. we could look at these rare mutations that you wouldn't necessarily get if you were targeting exons only. And then at the end of this plot, just pointing out some of the newer things that we're doing. For example, circulating tumor DNA testing that we launched a couple of years ago, and then HRD signature analysis we are developing. So we're not live with that yet, but we're excited to be live with that soon. Okay, so this is our kind of our workhorse panel, the sort of so-called UW OncoPlex, and also we call it OncoPlexCT for the circulating tumors. So just the important thing about this is what's at the bottom of this slide, bottom right, and that's the patient-tailored expert interpretation. So it is important to measure all of these things. You want to when you're doing a cancer test, either germline or tumor or paired, it's very important that it can detect all classes of mutations, copy numbers, gene fusions, and also the important signatures like microsatellite instability. Total mutation burden I'm not going to get into, but that's another biomarker that's important for immunotherapy prediction and has an FDA approval associated with it now. So we measure that as well. But none of these things work unless you have expert molecular pathologists reviewing the data. Sort of it's garbage in, garbage out. And reviewing the data means reviewing the specimen before you put it on the test, and it means reviewing the results in the context of the specific patient history before you report the results. So this is not a widget. This is a diagnostic medical activity. It's really not even a test in that sense. It's much more analogous to reading out like a complex resection case, and all the sort of workup that goes with that. And people sort of recognize that what we do in anatomic pathology is something that a physician does and who's gone to residency training and has lots of training. But the field hasn't really woken up to this with NGS testing. And if anything, it's actually probably more complicated, and it probably requires more sort of artisanal expert review if you're actually going to do it right than it does even to do sort of routine anatomic pathology. Maybe the more complex is not. So this is not automated. Yes, the bioinformatics are automated in terms of what's reviewed. Yes, there are automated pieces of this, but there's so much complexity. So that's the main thing I want to sort of emphasize. Of course, this is an audience that's probably friendly to that message. But I say that always to my medical oncology colleagues. I happen to live with one, so I get to say it all the time. How important it is that we don't think of this as a widget. We don't think of ourselves as pathologists as medical devices, because we're not medical devices. All right. So the other sort of paired testing that we've been doing more frequently at our institution we call BROCA-Tumor. So this is building on that cancer disposition panel that was developed in Mary Claire King's group by Tom Walsh that we brought on. And that panel just happens to be really enriched for DNA repair mutations. And so we're lucky in that it just happens to be perfect for PARP inhibitor and immunotherapy response prediction, because it just happens to have all those genes, because those are the genes that happen to be the ones that cause cancer. So the panel is already perfectly situated for that. So we started, in close collaboration with our gyn-onc colleagues, but also in colorectal and other groups. We developed pathways to do paired tumor normal testing upfront for both germline and cancer. So these are patients that, particularly ovarian cancer patients, they need to get germline testing anyway as standard of care. Anyone with ovarian cancer gets a germline panel now. And so we are able to then get that germline testing done and the tumor testing done up front and get all the information they need, both for treatment and for risk counseling up front. And so I think this is increasingly going to be the paradigm, and not just for ovarian cancer. I think it's going to spread out. And again, I think it's going to be driven by these things like HRD signature analysis, and all these other factors that are converging around. We're just going to probably have to do paired germline and tumor testing up front. And I don't mean like paired germline and tumor where like the germline is just a control for the tumor so you get better data from the tumor. Like we're going to be a germline report, here's what your risk is, and then there's going to be a tumor report. It's going to be part of the same test. That's where I think we're going. So again, I want to emphasize this patient-tailored expert review. So we're lucky at the University of Washington. We have so many talented people. I'm really lucky to work in a very large group of molecular pathologists. We now have oh gosh, we have now 9 faculty in our division who are all just fantastically talented, and we work as a team. And so again, we do have a fancy bioinformatics pipeline that we've worked and poured our heart and soul into that does just amazing things. I like to call it's like the Millennium Falcon of NGS. It just does amazing things. So the automated part is really important, but that's only the first part, right? So you get this great automated piece, and then it goes to the way we do is a team approach. So we meet every week and multiple people review the raw data. It's not just like, here are the variants, let's talk about it. Like multiple people are going to go in and review the raw data so we can come to consensus at that level. And then we have tumor boards for multidisciplinary review, and then of course reports. But I know this model isn't going to work everywhere, but it is something that we find to be both important for optimal patient care, but also really, at least in the academic setting, really facilitates research and academic collaborations, and also importantly, training. All these are great training opportunities, again, if you're in the academic environment, to have this sort of a team approach. So we really believe in it. It's the best medicine, it's the best training, it's the best research. So we have now 4 disease-specific molecular tumor boards that meet at our institution. The oldest one is the Prostate Genitourinary Board, the one that I lead, that's been meeting since 2013, and I'm giving it later today, or our molecular genetic pathology fellow is. This is something that is really, really popular, and it's been very successful. So many discoveries have come out of this, including that this was what spurred me getting involved in that cancer team that resulted in that study with the germline mutations in prostate cancer. So I mean, this is really a lot has come out of this. It's been really exciting. And then we have other of our faculty who kind of lead disease-specific tumor boards. So this is just one model. And again, I know it's, a lot of places do pan-cancer molecular tumor boards, which is a perfectly fine model. We find that we have enough cases and enough bandwidth that it makes sense to do these disease-specific models. Okay, so shifting gears to tumor sequencing and a germline workup. So now I'm going to be talking about, again, the tumor germline interaction. I'm going to be talking about cancer predisposition and how the testing of both can help here. I'm going to focus on Lynch syndrome because I think there's some really interesting ways in which tumor germline testing is come into play here. So what is Lynch syndrome? Again, people with inherited mismatch repair mutations. It's as common as 1 in 300 people. About 3% of people with colorectal cancer have Lynch syndrome if unselected. And universal tumor-based screening is now recommended. So we've been doing tumor-based testing for Lynch syndrome screening for decades. But historically, we've selected out only patients that are really at the highest risk using criteria like Amsterdam and Bethesda and so on and so forth. And what we've recognized just in the last few years is we've missed a lot of Lynch syndrome patients when we use these really selective criteria to look for people who are really young or only had a really strong family history of colorectal or endometrial cancers. So now the recommendation is just screen everybody who has colon cancer and increasingly endometrial cancer for Lynch syndrome. So we're doing universal testing on colorectal cancer using MSI or another mismatch repair deficiency test like IHC. And in the course of doing this, we've uncovered some interesting new biology that wasn't really well understood until the last 5 years. And so to cut to the chase, it turns out that Lynch syndrome is about 3% of colorectal cancer, but there's also about 3% of colorectal cancer that is the so-called double somatic flavor of mismatch repair. And so that's cancers that have 2 mutations, biallelic, both copies lost of a gene like MSH2, MSH6, MLH1, MLH1. And this isn't that surprising that colorectal cancers would have double somatic mutations in these genes, but it wasn't really understood. Even when I was a resident, I was taught, well, you either have Lynch syndrome or you have mismatch repair deficiency caused by MLH1 methylation. That's the sporadic mechanism. That's what I was taught, like not that long ago. And yes, MLH1 methylation is the most common sporadic cause of mismatch repair deficiency. That is not germline. But double somatic is also as common as Lynch. And so the reason this is important is because when you screen everybody universally, if you don't do that careful ascertainment to only look for patients that are very likely to have Lynch syndrome, now when you detect mismatch repair deficiency and you've excluded MLH1 methylation, you're now 50-50 between these two causes. And so because people have been taught a certain way, people are really confused. Well, I have a mismatch repair deficient positive result. I've excluded the sporadic cause. I excluded MLH1 methylation. So this patient must have Lynch syndrome. But I tested their germline and it's negative. So gosh, I guess that germline test must have just missed their germline mutation because I know they have Lynch syndrome. And the answer is no, they have double somatic mutation. So there's actually a testing reason to prove that for reassurance. So I call it like undiagnosing Lynch syndrome. So that's the use case, and we do it all the time. And it's actually even in the NCCN guidelines. So there's a recommendation to consider somatic testing of mismatch repair genes in some scenarios where germline testing is negative. And this has been in the guidelines since 2015. And in part from work that was done with myself in collaboration with Heather Hampel and Albert de la Chapelle at Ohio State. So we've been doing this what we call colorectal tumor, this tumor germline testing to sort of undiagnose these Lynch syndrome cases that are unexplained for about 5 years. And we're about to publish our clinical series. So this is just to kind of show you a breakdown. This is work led by talented genetic counselor in our group, Angie Jacobson, and Eric Connick, one of the talented molecular pathologists in our group, also shown as Brian Schertz, who's involved with this. So basically, the bottom line is if you in a clinical testing series where you've ascertained on these patients that these are patients that have a positive screening result, so they have IHC loss or they have MSI, and they've often already done MLH1 methylation, but not always. They want to explain, why did I have a positive screening test? And so we're doing tumor and germline paired testing to look for that. So when we do that in our series, 75% of the time it's double somatic. So again, this is highly ascertained. There's already been germline testing negative as well. So it's highly ascertained, but we solve most of these cases, and it's very helpful because these patients otherwise would have been called, quote, Lynch-like, and would have been screened with like annual colonoscopy and stuff like that as if they had Lynch syndrome. So this is a huge public health benefit to undiagnosed Lynch syndrome. We can explain why you had a positive screening test. You do not have Lynch syndrome. Your tumor has somatic mismatch repair, and we've proven it. So that's what it is. But importantly, it's not all double somatic in this ascertained series. There is some missed Lynch, and so that's useful. So we do 7% of the time we do find that it was a missed Lynch mutation. So it's still helpful as a second gut check. So tumor NGS can explain mismatch repair deficiency after germline is unexpectedly negative. The other thing we've done with tumor sequencing and germline sequencing the Lynch syndrome is because we do so much tumor NGS, we were wondering, can we just use tumor-only testing as a Lynch syndrome screening and forget about doing IHC, forgetting about doing traditional MSI, just tumor NGS. We're doing it anyway for a larger and larger swath of colorectal cancer and endometrial cancer patients for treatment, obviously in late stage. So why not just at the same time you're doing that test for treatment, also do your Lynch syndrome screening? So we did this prospective study with Ohio State where they were collecting every colon cancer in the state, and we compared that approach blinded to traditional Lynch syndrome screening approaches with MSI, IHC, and the other assays. And bottom line is it worked great. It worked better than traditional screening methods, and also really dramatically simplified things. So on the left of this slide, what I'm showing is just super complex algorithms that have come into Lynch syndrome. I mean, it's just gotten to be crazy. It doesn't have to be this hard. It should just be like, is it positive for a Lynch syndrome screening test or is it negative? So tumor NGS can simplify that because you can do all these various subtests all in one piece and just get an answer. And so the bottom line, and this is again work that we collaborated closely with Heather Hampel and Albert Taylor Chappelle and others at Ohio State on, and what we're calling tumor first basically didn't miss any Lynch cases, whereas traditional screening approaches with MSI or IHC missed some Lynch syndrome cases. So not only did it work as well, it worked better. And that shouldn't be too surprising because I think the MSI works better using NGS, and you can actually look at the underlying mutations. So the last thing on the sort of syndrome workup that I'm going to talk about just very briefly is tumor data being used to aid in germline variant interpretation. So particularly again with Lynch syndrome, I think this can be helpful. And it's increasingly being used for BRCA1 and BRCA2. So the scenario I'm talking about here is you've got a germline variant of uncertain significance. It could be pathogenic, it could be benign, it's in the germline, you don't know, it could go either way. So, well, gosh, if it's in the mismatch repair gene and you look in the tumor and you see that the tumor has the signature of mismatch repair deficiency, that's probably going to push you more towards pathogenic. It's not enough, but it helps. So that's the idea. And the same with HRD and BRCA1 too. So when might this be helpful? There's a wide variety of the sort of VUS category of germline variant. And really it's going to be in those high cases where the VUS is close to being called likely pathogenic, or in those low cases where it's close to being likely benign. So if you're kind of right in the middle, it's probably not going to push you one way or the other. But if you're almost going to call something pathogenic, I think looking at a tumor could push you over the edge and should, and vice versa. And Brian Schertz in our group has done some really nice, very formal modeling to show this. He's published on this recently in American Journal of Human Genetics, showing likelihood modeling and how this tumor testing can be formally incorporated into like ACMG variant classification guidelines. So you can do some real math around this and codify it. And we're excited to see that how tumor testing becomes part of a germline workup in that way. And so we've done this in our group. There are 40 patients with germline mismatch repair variants of uncertain significance. That we looked at, and 5 were reclassified in PARP based on tumor sequencing, 4 going up to likely pathogenic. And again, this is that paper I referenced from Brian Schertz's group published a couple years ago. Okay, on the last section, okay, shifting gears to liquid biopsy. So again, the theme, tumor germline interaction. So circulating tumor DNA testing in the plasma is increasingly used, but there really is no standardization on tumor content or on clinical features. So both of these things matter a lot. If you have early stage disease, you're usually going to have none or very little circulating cancer. So basically, it's garbage in, garbage out. You're not testing the tumor. It's like putting a needle in someone's arm to test their prostate cancer. It doesn't make sense. So you kind of miss the tumor. The language I'm trying to use with my oncologist colleagues, it's like a non-diagnostic biopsy. Like you missed the cancer. They understand that because they get it. If you do a biopsy and there's no cancer in it, then you can't actually test for something. I think that's good language to use. So, but there's no standardization on that right now. I mean, you don't have to prove that there's cancer in the plasma before you do the test. That's a problem. There's no standardization on clinical features. Again, on what stage do you need to be? Do you have to have specific features for the test to work? And there's this massive overemphasis on test sensitivity. I have no idea why. It's just, oh my gosh, it's 0.01%, and you detect a allele down to 1 in 100,000, and I'm just like, who cares? This is not the problem with these tests. The problem is specificity and lack of standardization on tumor content. It's not that sensitivity isn't important and limit of detection isn't important. Of course they're important. And yes, of course we're going to have low amounts, but I just don't understand why that's all that's ever discussed is, well, how sensitive it is. And, oh, it's such a problem that there's not enough, their tests have to be super sensitive. And if anything, this is contributing to these errors because we have so many clinical false positive results from these overly sensitive tests that are by and large measuring clonal hematopoiesis, which is not cancer. So inconveniently, the same genes that we're using for FDA-approved targeted therapies are mutated with pathogenic mutations in processes like clonal hematopoiesis. And those mutations do get into the plasma. And when you do a plasma-only test, you do measure them. And it's not infrequent. I mean, like all the time. So results from plasma-only tests that are ultra-sensitive and are unthinking in terms of how much tumor content there is are going to be making massive diagnostic errors. I'm saying that in strong words because I think there's a crisis coming if we don't get our act together with this, because it's pretty scary. So clonal hematopoiesis, it's well understood at this point. There was a couple of papers, I wasn't involved in any of this research, a couple of landmark papers that came out 5 or 6 years ago, really describing how age-related clonal hematopoiesis is extremely common. But also we've recognized since then that treatment-related clonal hematopoiesis is also common. So this is work that I was involved with where we looked at ovarian cancer patients that had cytotoxic chemotherapy and showed that clonal hematopoiesis was very common after treatment, and other groups have replicated this too. So you can have age-related clonal hematopoiesis, you can have treatment-related, and it's not a matter of if you have this, it's a matter of at what level. So several groups, Liz Swisher, Rosanna Risquez, others have shown now that if you use super sensitive methods, like you can detect things like down to 1 in a million, and you have enough molecules, you'll find we all have it. I have it. Everybody on this call has it. We all have it. So it's not about if you have it, it's at what level you have it. So if you have the perfectly ultra-sensitive cell-free DNA assay, and you're unthinking about how you're analyzing the data or reporting it, every single one of us should get a PARP inhibitor right now, according to this test. So that's not good. So we got to think about specificity. So what we've done in prostate cancer, we did a large clinical series with our OncoPlex circulating tumor data, and instead of focusing all on sensitivity, we really wanted to focus on clinical features. What are the clinical features that really predict a very adequate study for prostate cancer, which is what we were most interested in. And it turns out you can do a pretty good job with this. So if you look at metastatic disease and you look at patients that have metastatic disease and have PSA over 10, you tend to get adequate studies, and that's what this green is showing. These are actually prostate cancer mutations we're detecting in plasma. Once you get to be lower tumor content, these are red. So these are ones that were missed in plasma and were tumor only. So basically, you can select a pretty good disease state. And the reason this is helpful is that even if we had a much more sensitive assay, again, we're going to be testing mostly clonal hematopoiesis once we get down to those low tumor content. So it's a pretest probability game. And this has been shown in groups. This was a group that sent tumor studies to 2 different labs, same sample. So just split the blood, 2 different commercial labs, prostate cancer patients. Basically, there was only like 6 out of 40 that had any congruence, or it was maybe a little bit more. And then the scary thing is the things that were congruent were probably chip clones. They didn't say that, but when you dig into the data, it's only these guys with the high PSAs where it look like there's actually prostate cancer mutations. The guys with the low PSAs, which is shown up here, these green are the congruent. We know now from what we've seen, these are in P53 and these common clonal points. So these are probably congruent, but false positives. So that's even worse. So this is not good. Now, again, I don't mean to sort of say cell-free DNA is such a great modality, and it is a very important diagnostic testing modality, and it works. So I want to emphasize that. It works. It's just that we've got to be more thoughtful about this, and we probably need to start thinking about doing plasma and whole blood, that is plasma and germline paired testing, because of clonal hematopoiesis. Because the good news is it's easy to subtract. You just do a whole blood control for the germline, and well, in this case, the white blood cells, and you can subtract out that clonal hematopoiesis signal, and then you know for sure that at least the somatic mutations you're seeing in plasma are not clonal hematopoiesis. So the scary thing again is that we've looked at this recently in prostate cancer. We looked at a series of 69 cases. Not that many, but we did paired plasma and whole blood in guys with advanced prostate cancer. And we found about 10% of them had clonal hematopoiesis in genes that are FDA-approved indications of PARP inhibitor, and these were at high variant fraction. So this was not subtle. Okay, so this is a scary, scary thing. It was mostly ATM, but we did have BRCA2, and we also had CHEK2. So we know that this isn't going to be a small problem. This is going to be a big problem, and that's not surprising for prostate cancer because these guys it's a double whammy. They're older because it's a disease of older people, so we're going to have more age-related clonal hematopoiesis, and they've often already had docetaxel, which is a cytotoxic, which is a chemotherapy. So that's probably we don't have data to prove this, but we're speculating that having had prior chemo also may be predisposing. We don't know that for sure, but certainly they're older, and so in prostate cancer in particular, it may be a bigger problem than other cancer types, but nonetheless, there are FDA-approved indications, and we can see that. And actually, when we look, it's actually as common. So if you have a mutation that predicts PARP inhibitors, if you did a plasma-only test, only about 50% of the time would that be a true signal. So that means half the time you're gonna get a problem. Okay, thanks for this is my last slide, so I'm getting a 3-minute warning, and okay, I'm doing okay. All right, so germline and tumor NGS testing of DNA repair genes increasingly needed to guide cancer treatment. Tumor NGS testing increasingly used in the cancer predisposition workup. I talked about Lynch syndrome as an example and the sort of tumor normal testing. And then I talked at the end about paired plasma and whole blood testing to improve performance of liquid biopsy, and want to highlight the work of our recent MDP fellow, Kendall Jensen, who was picture I showed there. We did that nice study I just highlighted. And thanks really to the whole genetics and solid tumors lab at the University of Washington, many colleagues. I'm really, again, lucky to work in such a large and cohesive group. It's really all of this work I talked about was a team effort, and very little of it was just for me. So thanks very much for your time.
Thank you very much, Colin, for that great presentation. I think you really made a strong case for doing paired tumor normal sequencing for a variety of different reasons.
So questions, doesn't look like we have much on the board. I'll let Caroline and Jim let us know. But Colin, I just want to echo, thank you so much for very nicely kind of outlining why the job that we do as molecular pathologists and our genomic analysts, our genetic counselors is so crucial. I think that this is something that I think we are challenged here at the University of Minnesota, just trying to make that case to our geneticists, our pediatric geneticists, our neurologists, our medical oncologists, as far as how much value there is. I actually have a slide in a different talk that's called farm to table genetic testing from the standpoint of, local is better. And you need to,
I'm gonna steal that. Farm to
I'll send it to you. I mean, because it's you really set a really nice stage. I think it's given me a lot of ways to think about how to talk with our colleagues of just how much integration one can do when you have all of these different tools at your disposal. So again, thank you.